We are delighted to welcome Dr. Shahram Majidi, an assistant professor of neurosurgery, neurology, and radiology, speaking to us today about acute ischemic stroke. Dr. Majidi.
Thank you very much. I'm going to share my screen. Okay, do you see my slides? Wonderful.
Yes.
So we're going to talk about management of acute ischemic stroke from emergent large vessel occlusion, talk about past, present, and future of this treatment. My disclosure, no related financial interests. I've been supported by American Heart and Stroke Association for my research activity and funded by Society of Neurointerventional Surgery. So a little background, approximately 800,000 new strokes happen every year. Someone in the United States has a stroke every 40 seconds, and every 4 minutes, someone dies from stroke. Sorry, I see some background noise I need to make. Okay. Sorry for the pause. So number of the visit to emergency department throughout the country as primary diagnosis of stroke is close to 600,000. Stroke is the 5th leading cause of death and the top cause of disability in the country. And it costs the United States an estimated $40 billion financial burden every year. It used to be 3rd top cause of death just several years ago, but due to the advances in the stroke care, this has now dropped into 5th. So I will start with a few case presentation and just illustrate what we do for stroke care now, and then we will take from there. So case number 1, 84-year-old gentleman with hypertension, diabetes, hyperlipidemia, pretty independent at his baseline, presented with altered mental status, dysarthria, worsening weakness in all 4 extremities, with NIH stroke scale score of 22, and a modified ranking scale of 0, meaning like independent at his baseline. He was outside of time window for TPA, which is based on AHA guideline within 4.5 hours from symptom onset. This was a wake-up stroke, so patient was not eligible for TPA. Exam, also I wanna highlight here, usually patients with acute stroke, they don't present with altered mental status. Usually exam is kind of lateralized to one side and patient is awake and aphasic or dysarthric, except when you have basilar artery occlusion. Just remember, in basilar artery occlusion can be a little confusing and challenging because of the involvement of brainstem. Patient can develop respiratory failure, altered mental status, and present with weakness on both sides. So this was classic presentation for basilar. We did a CAT scan here and CT angiogram. In the CT angiogram here on the left side, you see that there is a lucency and filling defect in the top of basilar artery. And here in the coronal section, you also see contrast is coming up from the vertebral artery up to the basilar artery, and then you see the filling defect in the top of the basilar artery. This is confirming the acute occlusion of the basilar artery. The patient is very disabled and couldn't maintain the airways, had to be intubated. So patient was immediately taken to angio suite for endovascular thrombectomy. He wasn't eligible for IVTPA, so came to angio suite. This is a vertebral artery injection. You see the left vertebral artery filling up and coming up. This is the right vertebral artery, but the basilar here is occluded. You see the cutoff at the top of the basilar artery. Single pass of thrombectomy using aspiration device. Now on the right side, you see the basilar artery is open with distal perfusion into the basilar artery territory. This patient completely disabled. In 3 months, when he came to follow-up visit, he was back to his baseline with no residual deficit from stroke. This could not be possible if we didn't have thrombectomy service available. So the next patient, 58-year-old lady with hypertension, AFib, hyperlipidemia, presenting with left-sided hemiplegia, neglect, and dysarthria, NIH stroke scale of 18, again, independent at her baseline, very functional woman. We did a CTA, showed a right MCA occlusion. Patient was in the TPA window, received IV TPA, and then because of the presence of large vessel occlusion in the CTA, was transferred to angio suite for emergent thrombectomy. Here you see our catheter is up. Here, this is on the left side, you see the AP view of the head, catheter in the right internal carotid artery. Contrast is coming up, filling the right ACA. However, there is a cutoff in the MCA, so there is no cerebral perfusion into the MCA territory. You see that there is no contrast going into the MCA territory. So again, a single pass of thrombectomy using aspiration device. You see that the ACA is, MCA is now filling. The full reperfusion of the cerebral circulation, and the patient was discharged within 48 hours with no residual deficit. So with these two cases, let's see how we reached this point that we have such a game-changing treatment for acute ischemic stroke from large vessel occlusion. So talking about ischemic stroke, IV TPA is a standard of care for patients presenting with acute ischemic stroke within 4.5 hours from symptom onset. This is based on NINDS TPA clinical trial in 1995 and a European clinical trial a few years later, which demonstrated TPA is superior to placebo in patients with acute ischemic stroke within 4.5 hours from symptom onset. However, as you imagine, there are a lot of patients who are not eligible for IV TPA, and roughly nationwide, less than 25% of the patients when present to the hospital are eligible for IV TPA. Most common reason is late hospital arrival, and also sometimes due to other contraindication, including being on anticoagulation, recent major surgery, because as you know, a thrombolytic therapy can have some side effects, or previous history of ICH. So many of the patients are being excluded from IV TPA therapy. Before I go forward, I want to also give a little definition of some of the common abbreviation and definition that we use in stroke treatment. So one is NIH stroke scale, which is NIH stroke scale score. It's a standardized neurological evaluation for the stroke patient. All our nurses, PAs, NPs, resident fellow, they are all certified in evaluating patient for NIH stroke scale, which is a standardized eval. And then modified ranking scale, which is a patient baseline functional status. You have aspect score, you may hear from stroke team, which is the Alberta Stroke Program early CT changes, and LVO, which is largest vessel occlusion, and eventually TK score, similar to what we have in the cardiac literature, but here in cerebral infarction. So again, NIH stroke scale is a scale of 0 to 42. It was developed as part of the NINDS IV TPA trial. And it's a reproducible scoring system to report stroke severity. Usually less than 5 is mild, 5 to 15 is moderate, 16 to 20 is severe, and more than 22 is severe. So, and then we have aspect score, which is the Alberta Stroke Program early CT score. It's a 10-point quantitative CT score to identify early ischemic changes. We identified 10 different locations in the CT scan of the MCA territory, which is M1, M2, M3, M4, M5, M6, internal capsule, lenticulate, nucleus, caudate, and insula. So when there is a loss of gray white matter differentiation in any of those territory, we subtract 1 from 10. If there is a patient with normal CAT scan, aspect is going to be 10. If there is a patient with already infarcted territory, aspect is going to be as low as 1, 2, or 3. And then I talked about modified ranking scale. This is one thing that has been used in all stroke clinical trials, basically standardizing patient baseline functional status. It's a scale of 0 to 6. 6 is dead, 5 is severe disability, bedridden, and 0 is no symptom at all. And usually when the modified ranking scale is less than 3, that is being considered as functional independence as baseline. So, and then LVO, which here, if you look at in this cartoon of the cerebral circulature, ICAs are coming up on the sides and the basilar artery on the back. If there is an occlusion of the distal ICA terminus, internal carotid artery terminus, or proximal MCA segment, or proximal ACA, that is being considered as large vessel occlusion. So all this being said, we're basically standardizing stroke care. The communication is very straightforward. As you know, time is brain, so we don't need to do really full neurological evaluation. We just do a quick NIH stroke scale, and when we communicate with each other, we say, okay, 80-year-old gentleman presented with NIH stroke scale 20, aspect 10, modified ranking scale 0, last node normal 5 hours ago. That's it. That's all we need to know to make the decision about first IV thrombolytic therapy, and number 2, if the patient is eligible for endovascular thrombectomy. And then talking about endovascular thrombectomy, we have thrombolysis and cerebral infarction score, or TK score, which is a score of 0 to 3. 0 is complete occlusion, and 3 is complete reperfusion of that vascular territory. Usually a score of 2B or better, which is more than 50% of the revascularization or reperfusion of the vascular territory, is being considered as successful recanalization. So that being said, then this is a study that we did when I was at NIH a few years ago. We looked at the efficacy of the intravenous thrombolytic therapy for restoring blood flow in acute ischemic stroke. So not surprisingly, as we could expect, patients with early reperfusion after IV TPA were those who didn't have large vessel occlusion. That means, like, if there is a proximal occlusion in the cerebral vessel, like middle cerebral artery, ICA terminus, IV TPA itself is not sufficient, is not strong enough to bust the clot and open the vessel. You see here that with ICA terminus or proximal MCA occlusion, the rate of recanalization with only IV TPA was only 24% versus patient without proximal occlusion could have reperfusion up to 50% of the time. So that highlights the necessity of stronger treatment for patients with large vessel occlusion on top of thrombolytic therapy. And this also reminds us how we kind of followed cardiology history in terms of thrombolytic therapy when they started initially with IV thrombolysis and then catheter-based intervention, and they enhanced their system of care in 80s. And in 95, here you see in the blue that NINDS IV TPA trial came, so that became standard of care. And then from 1995 to 2015, numerous clinical trials examined the efficacy and safety of intraarterial therapy, catheter-based intervention in the stroke treatment until in 2015, when all this clinical trial essentially demonstrated efficacy and safety of this treatment. So this is one of the earliest endovascular therapy clinical trial in stroke, known as PROACT-2, which looked at the intraarterial pro-urokinase for IV for ischemic stroke. With the catheter, you go into the intracranial circulation and inject intraarterial thrombolysis. It actually demonstrated higher rate of recanalization. However, the hemorrhage rate was much higher, 10% versus 2% in placebo. And further, later in early 2000, then we had the concept of mechanical thrombectomy, meaning instead of just doing intraarterial thrombolysis, you use catheter and a stent retriever to retrieve the clot. In 2004, a few companies, including Stryker, developed a device called Mercy Retriever, which was approved by FDA for acute ischemic stroke. Here you see 3 different generations of Mercy device, A, B, C. You take the device up to the clot, engage to the clot, and try to pull back and take out the clot. And based on that, we have the Mercy and multi-Mercy trial, which demonstrated 48 to 57% rate of recanalization with using this device. Here you see that the catheter goes to the clot, the device cross the clot, engage the clot, and pull out the clot into the catheter, and then you remove it out. So based on all these new developments we had in 2010, 11, and 13, we have few clinical trials. One was a MR rescue study, which was randomizing the patient within 8 hours from the last known normal to undergo mechanical thrombectomy using Mercy Retriever or Penumbra system, or standard of care, which is a medical therapy. The study showed that favorable penumbral pattern on neuroimaging did not identify patient who would benefit from endovascular therapy. Essentially, the trial was a negative trial. However, I want you to remember that the rate of recanalization was only 27% at that time, which is very close to what a TPA can do, intravenous TPA can do. And then in 2013, we had this famous IMS-3 trial, which was interventional management of stroke 3 trial. Again, this trial was also negative, did not show superiority of the endovascular therapy to standard of care in acute ischemic stroke. In this trial, again, I want to highlight that the rate of recanalization was only 38% in ICA and 45% in proximal MCA occlusion. So based on that, now we are in 2013, there was an editorial came out in one of our main journals saying that perhaps we should slow down the fellowship training for neurointerventional, because with all this negative trial for ischemic stroke, there's not enough procedure to be done by endovascularly trained trainees. So that's where we were in 2013. However, the technology didn't stop there. Newer, larger catheter, safer catheter were continued to be introduced to the field. The problem that we had in 2008, 2010, the devices that I showed you, Mercy device or early generation of Penumbra devices, were not as safe as what we have today. So there were a lot more complication, higher rate of hemorrhages or vessel rupture. But with newer generation, you see that in 2008, we had a newer generation of Penumbra devices with recanalization rate up to 82. Just compare that to 35 that I showed you in the IMS trial. Now we are up to 82. And then stent retriever was also introduced to the field. Here you see that a solitary stent retriever, much differently designed, safer navigation, safer inside the vessel compared to the Mercy device that I showed you a few slides before. And then Trevo came by Stryker in 2013, which again specifically was designed for stroke thrombectomy, flexible tip, standard deployment, and then sheathing vertical strut to maximize clot penetration. And FDA approved this for recanalization, and you see the recanalization rate was up to 86%. Basically, now we have a safer device, higher rate of reperfusion, and less complication rate. And these are the different devices from different companies that we have now in the market: Trevo, Solitaire, Embotrap, different, and Penumbra stent retriever. So similarly, our catheter were also getting bigger, larger bore catheter that you can easily navigate to the intracranial circulation and aspirate the clot out. Was not possible 10 years ago, but now with improving technology, it is safe to advance the catheter up to the intracranial circulation. And again, this illustrates how in 2004, we had the Mercy device, and then gradually we improved to different generation of the newer device until in 2012, our catheter were much navigable, safer to go to intracranial circulation, and the better design stents that could engage the clot safely without rupturing the vessel and opening the circulation. Another illustration showing that early days of devices until now that we have specifically devices that are specifically designed for thrombectomy and much safer. That all resulted in 5 different clinical trials, all published in 2015, and all of them showed that endovascular thrombectomy is safe and effective for treatment of acute ischemic stroke. Remember, from 1995 till 2013, everything was either negative or was associated with lower, some safety concern, higher rate of hemorrhage and vessel rupture. But only in 2015, we had 5 clinical trials. They all published in New England Journal of Medicine from Europe, Canada, and the United States that showed efficacy of endovascular therapy. This is the summary of these 5 trials: Mr. Clean, Escape, Extend IA, Swift Prime, and Revascade. This is the number of the patient that each of them enrolled. And I want you to pay attention here. Look at the rate of the recanalization, much higher than what I showed you with Mercy device or other older generation of catheters. So it shows that majority of the patients receive IV TPA still. It's a standard of care. And we obtained TK recanalization in more than up to 88% of the patient. And this is showing 90 days functional independence. As you see, it is much higher in endovascular arm compared to the medical arm. This is, I apologize, this is probably a little small of font here, but this is a pooled analysis of 5 clinical trials which demonstrated benefit of endovascular therapy across the age from 18 to even patient older than 80-year-old. Different aspects score, whether the patient received IV TPA or not, still they benefited from the stroke intervention, and also independent of sex and NIH stroke scale. So based on that, in 2015, American Heart and American Stroke Association, they updated their guideline. The guideline, which was published in 2013 and was endorsing against endovascular therapy. Now there was a class 1 level A evidence that patient eligible for IVTPA should receive IVTPA and then go for endovascular therapy if they meet all the inclusion criteria. What was the inclusion criteria? It was baseline functional status independent, and then proximal intracranial occlusion, which included ICA terminus and proximal M1, age more than 18, NIH stroke scale more than 6, which means that the deficit was disabling. An aspect score more than 6 or more, which says that the infarct core is not big, meaning there is still salvageable brain tissue, so the endovascular therapy won't be futile. And the treatment should have been offered within 6 hours from symptom onset. This is the AHA guideline in 2015. And then based on that, remember in 2013, there was a editorial saying that we should shut down the endovascular training. Now in 2015, editorial published that now there is an urgency that we don't have enough operator to provide endovascular therapy for stroke, now that stroke endovascular therapy is very effective. So things can change very rapidly. So that being said, treatment of stroke did not stop in 2015. Then we started thinking about patient selection a little more using advanced imaging, not just dry CAT scan and CTA. We started utilizing and studying CT perfusion, MR perfusion. So then started postulating about the benefit of patient presenting beyond 6 hours from symptom onset. What about those patients? The presence, if there is a clinical deficit that is disproportionately severe relative to the volume of the infarcted tissue, are those patients are still eligible for thrombectomy? So for example, I will show you this MRI here. Perhaps that will help to convey my thought here. This is a patient presenting 12 hours from last node normal with a left M1 occlusion. You see that there is a cutoff in the M1 here on the left side, on the right side of the screen and the left side of the brain. Right MCA is patent, but there is a left one occlusion. The MRI, the picture in the middle is the MR perfusion, which shows large deficit here in the left hemisphere. And the picture on the left side is DWI or diffusion weighted imaging, which is showing only a small infarct core. So infarct is still small, but there is a much bigger tissue at risk, or we call it penumbra. How we calculate that? There is a system that calculates the flow to that vascular territory, blood flow, and also blood volume. When there is a decreased blood flow to that vascular territory, but the volume of the blood are still preserved, that is called penumbra, and that gives us the hint that that part of the brain is at risk of having a stroke, but is still salvageable. So this is the advantage of using advanced imaging. So you can differentiate between the penumbra and the tissue at risk compared to the area of the brain which is already infarcted and not salvageable. That is not possible with only CAT scan, but advanced imaging such as CT perfusion, MR perfusion can help that to differentiate that. With that, then in 2016 to 2018, another clinical trial, multi-center clinical trial was conducted looking at the thrombectomy in patient presenting 6 to 24 hours from symptom onset with mismatch between deficit and infarct, meaning like infarct core is small and there is still salvageable brain tissue. They enrolled patient more than 18-year-old, NIH stroke scale more than 10, still patient with good baseline functional status, and they use advanced imaging such as CT perfusion or MRI to identify infarct core, and also then look at the mismatch between the infarcted area and salvageable brain tissue. This was the first trial in 2018, was published as DAWN clinical trial, which demonstrated that patients with ICA or M1 occlusion who presented within 6 to 24 hours from last known normal and who had large penumbra, salvageable tissue, and a small infarct core, endovascular therapy is still superior to medical management, and those patients can benefit from endovascular thrombectomy. And this is actually very important. Perhaps there are very, very few, if any, treatment in the entire medicine with number need to treat of 2. They demonstrated that for every 2 patients who underwent thrombectomy, 1 additional patient had a better score of disability at 90 days. And they also showed that for every 2.8 patients who underwent thrombectomy, 1 additional patient had functional independence at 90 days. Very, very effective treatment if you use advanced imaging to identify selected patients who will benefit from this therapy. Parallel to DAWN trial, there was another study run, multi-center studies based in Stanford called DEFUSE 3. They also examined the same thing, thrombectomy in extended time window beyond 6 hours. Again, inclusion criteria was NIH stroke scale more than 6 or greater, meaning disabling deficit, and then occlusion of the proximal M1 or ICA terminus, and mismatch in the CT perfusion or MRI, meaning there is a small infarct core, but there is a larger salvageable brain tissue based on the CTP criteria. This trial here, this is one of the patient which was enrolled in DEFUSE 3, and this was enrolled using MRI. Here on the left side, you see the infarct core, small, relatively, only 23 cc. However, on the right side, as highlighted as green, you see the penumbra or salvageable tissue, which is 128 cc. So you see that the software and the advanced imaging give us the opportunity to quantify the the volume of the infarcted brain and also compare it to the salvageable brain tissue. So this is what we call mismatch. There is a 105 cc salvageable brain tissue. So therefore, this patient is eligible for therapy. So DEFUSE 3 also showed that endovascular therapy plus medical management as compared with medical therapy alone was associated with higher percentage of the patient who were functional independent at 90 days, 45% versus 17%. And also at 90-day mortality rate was 14% in endovascular arm compared to 26% in the medical therapy arm. And there was no significant difference in the frequency of symptomatic ICH. Remember, I showed you early trial in early 2000, the rate of hemorrhage in the endovascular arm was 5-fold bigger than medical therapy. But now in 2018, based on advances that we had in the field, better technology, better training, the rate of symptomatic hemorrhage is not different between the 2 groups. So that really provides us with a new dawn in stroke treatment. This is a famous slide here I wanted to highlight, as we know that for every stroke from large vessel occlusion, let's say middle cerebral artery occlusion, if we don't treat that patient will have 36-year of accelerated aging. And that patient will lose 1.2 billion neurons because of that stroke. This is if remain untreated. But time is brain. Even if we treat it, the treatment needs to be fast, because every hour the brain is losing 120 million. And every minute we are losing close to 2 million neurons. So time is brain is coming from this calculation. So every minute delay will cause further damage to the brain. That's why all these campaigns are going on by American Heart and Stroke Association, advocating for earlier recognition of stroke and stroke alert and activation of the stroke code. However, based on the advanced neuroimaging that I explained in the DAWN and DEFUSE 3 trial, now we know that although time is brain, however, it's different. Some people are fast infarctor and some are slow infarctor. There are people who present within 3 hours from symptom onset, half of the brain already infarcted and non-salvageable. And then there are patients who present 24 hours from last known normal, still very small infarct. Why is that? That's because of the way the collateral circulation works and the way the brain receives help from other vasculature. So we really don't know which patient is a fast infarctor, which patient is a slow infarctor, unless we use advanced imaging, meaning CT perfusion, MR perfusion, and identify and recognize this patient. So here, early clinical trial of a stroke, if the patient present within 6 hours from symptom onset, yes, most of them will be eligible for endovascular therapy. When the patient present beyond 6 hours, we are going to have to use advanced imaging to identify possibly few patients who might be eligible. There are going to be more patients who are already infarcted and not eligible for thrombectomy. So based on the new clinical trial, so AHA had to put another update in 2018 for providing that now there is a level 1 evidence that we already knew that endovascular therapy was effective within 6 hours from symptom onset, but now endovascular therapy is effective within 24 hours from symptom onset in a selected patient if we use advanced neuroimaging to identify penumbra and infarct. So this is just to compare mechanical thrombectomy. I showed you it is number need to treat for functional independence in mechanical thrombectomy within 24 hours is 2.8. That shows where that therapy stands compared to, let's say, defibrillation for VFib, let's say antibiotic therapy for lice, or let's say ASA for MI or bariatric surgery. So one of the most effective therapies in the entire medicine if we select appropriate patients. I would like to give few minutes for question, but before that, I wanna also highlight the future directions. Now, stroke therapy today, most of the patients are eligible for endovascular therapy. However, research continues. There are clinical trials looking at the efficacy and safety of endovascular therapy in patients with larger infarct. Is this possible if we offer this therapy even in patients with larger infarct, may prevent craniotomy, may prevent a long-term deficit? We don't know, but that's still under study. Or endovascular therapy in patients with who are not eligible for IV TPA. As I said, IV TPA window is only 4.5 hours. If the patient present outside the IV TPA with lower NIH stroke scale, should we take those patients for thrombectomy? And also endovascular therapy beyond 24 hours. I think we already have the answer for this question already. Time does not matter. imaging matter. If the patient presents with unknown last known normal and still has a favorable neuroimaging, meaning smaller infarct core and large penumbra, independent of the last known normal, we should offer them treatment and they will benefit based on the knowledge that we have from recent clinical trial. And also I want to highlight this with advances in the technology. Nowadays we have safer devices, more navigable catheter, which not only can go to proximal MCA or ICA terminus, but can be easily navigated to the distal branches like M3 or M4 branch of middle cerebral artery, or A2 or A3 branch of anterior cerebral artery. So these are not the territories that being studied with in the clinical trial. However, with advances that we had, it's now safer to even go after the clot in more distal branches. In future, we're going to hear more about distal thrombectomy and safety and efficacy of that. With that, I'm going to stop here and happy to take questions.
Excellent. Thank you so much for that. I'll let people add their questions to the chat, or maybe unmute themselves and ask their questions themselves.
Dr. Majidi, thank you very much for your discussion. I found it very interesting topic. I wanted to ask you, last year in the New England Journal was published the results of the direct MT trial, the direct MT trial, which looked at thrombolysis and prior to thrombectomy, and found that actually, at least in this trial, that thrombectomy alone was non-inferior to the combination of thrombolysis and thrombectomy. I wonder if maybe you could discuss that trial briefly, and do you anticipate, that this may lead to some changes in how these patients are treated with respect to thrombolysis as well as thrombectomy?
Very good point. This is one of the hot topics and debate in the stroke field now. Should we bypass IV TPA or IV thrombolysis and just directly take the patient for thrombectomy? Yes, that trial was basically showed that the direct thrombectomy is non-inferior to IV TPA plus thrombectomy. However, there is still a little resistance in the field. I personally think that IV TPA should be given for eligible patients, especially when the patient is being transferred from other centers. Sometimes there is delay in the transfer, there is delay in the thrombectomy, and in up to 10% of the time, thrombectomy is unsuccessful. So at least when thrombectomy doesn't happen or is not as successful as we wanted, we have the TPA on board. Because TPA is time sensitive, you cannot go back and give TPA after thrombectomy because patient is not going to be eligible. So I still think there is value in IV thrombolytic therapy for eligible patient. However, there are some selected situation. For instance, patient already has a relatively large infarct core. Patient has carotid stenosis that we are thinking about necessity of doing carotid stent during thrombectomy. In those select cases, perhaps TPA is not going to be on our side, because imagine there is a TPA on board and we want to stent the carotid, we have to load with integralin and put on dual antiplatelet. Those are difficult scenarios that we sometimes encounter, but in general, IV TPA should be still given for eligible patient, and this is still what American Stroke Association endorsed. And I also want to say that we also have TNK, tenecteplase, which is now being approved for IV thrombolytic therapy in a stroke. There are a few advantages with TNK. You know, IV TPA is 0.9 milligram per kilogram that you push 10% of it and then infuse rest of it over the course of 1 hour. But TNK is only one push. So there's no infusion, much faster, easier logistic for the drip and ship patient when you're pushing TNK and transferring to the thrombectomy center. And also the clinical trial have showed that the rate of recanalization with TNK in patients with large vessel occlusion is superior to TPA. So all that being said, I think you're gonna still hear about IV thrombolytic therapy in a stroke and even more, and it's not gonna go away.
Thank you very much.
Great. We have about 2 minutes left. Maybe we could take one more question if there is one. Nothing. All right, Dr. Majidi, I think you answered everybody's everything.
Thank you very much.
Thank you so much for joining us.
Thanks for having me. Again, my apologies for being late for the presentation.
No problem. Thanks, everybody.